Thank you, AIS, for giving me the opportunity to present this case talk on the optic disc maculopathy. So, optic disc maculopathy diagnosis has improved these days because of the advancement in the OCT. Earlier, we were not able to diagnose, and still we were unable to diagnose. Many of the patients come very late, and so the visibility is bad. With the advancement, we are able to follow up these cases and to predict early the neurosensory detachment or the decrease in vision, so that early surgery can be done. So, innovation. So there are two theories as far as the optic disc maculopathy is concerned: vitreous theory and the pressure gradient, that the fluid is coming from the CSF or not. The exact pathogenesis is not known. In some patients, it may be vitreous, it may be the CSF pressure, or both acting. So with the swept source OCT, there is a deeper penetration. So we can have a depth up to 2.6 millimeter, and we can know the course of and the depth of the pit. So that the management which is coming these days is the optic pit, stuffing, we can calculate. Dangers can identify the communicating tract. As you know, the fluid comes not from the optic disc, from the communicating tract which is laterally present. So this was a so identify OCT, SWEPSO OCT helps in identification optic disc pit and its communication. Early identify intraretinal fluid and SRF. Identify vitreomacular traction specifically over the disc, which is the main cause which has been found, and the prognosticate depending on the ISO junction, RP station, and monitoring of the treatment. So this is the one study where they have done the various swept source OCT. Here you can see the OCT on OCT they defined the optic disc pit, shallow pit or deep pit, and depending on that we can have a treatment later on. And the hole in the lamina cribiosa. You can go through this article. And as far as management of optic disc is concerned, there is non-surgical, surgical. But one of the important although this is rare, the identification of optic disc pit and the follow-up for the development of the maculopathy and neurosensory detachment is very important. So initially laser were tried when there was a vitreoretina was not advanced, then buckling was tried, and pneumoretinopexy, and at present plasma vitrectomy with its various modification is the treatment of choice. So there are two things: observation, and some people use the carbon anhydrase inhibitors. In optic disc pit, 25 to 75 per eye with optic develop the maculopathy. Resolution is very rare except in the pediatric cases. So now standard of care is that the plasma vitrectomy with or with laser or gas. Earlier we used to do ILM peeling, but tangential traction is not the cause in these cases. This is just to emphasize you. And now these days, because people are thinking the source is from the CSF in some cases, so there is a plugging of the optic disc pit. So these are the things PP will release the vitreous traction. Gas act as a temporary barrier. Let me tell you, one of the European studies, gas has a better prognosis. This I have learned for the last 5 years. Otherwise, there is no need to put the gas, only the X-ray, because this causes a tamponading effect and the absorption of fluids. ILM peeling as earlier we used to do, but no. Plugging is very important. Some people are trying inner retinal fenestrations and shown the results, but it is very difficult to do, and because of the surgical risk and involvement, we are not doing, but auto allows it. In plugging, one of the sources is the communication. So there are various methods which has been tried: ILM flap, autologous scleral patch, amniotic membrane, autologous fibrin glue, and Hassan et al. Has used the silicon lacrimal plug. So I will show the case 1. This is a case when the optic pit was diagnosed 6/6 vision, and you can see the fluid starts from the nasal, fluid was in the intraretinal space, and that it increased. As you, the vision is still 6/6. It took 3 to 5 years. Again, now you can see the small neurosensory detachment, which can only be picked by the OCT with the high resolution OCT. That is why we are doing 90D, all these things. It is very difficult to pick up and to decide when to do the surgery. Now the vision has become, now the neurosensory detachment has increased. Again, vision has become 6/12. Patient is not still symptomatic, but because we know if patient is not being operated, the patient has been convinced, we have done the surgery at this stage on the pars plana vitrectomy, so which everybody has seen, PVD induction, and that's all. Now this is the case pre-operative. As you can see, at vision 6/12, 871 thickness and 82 is a neurosensory detachment. And after 1 year of just doing PPV with the PVD induction, the vision has improved to 6/9, and there is a still small defect, and the thickness has decreased 309. This is the only case where we are following for the last 7 years. Now this is the second case. Now the thing is, some cases there is recurrences around 30 to 40%. The percentage not matter. Recurrence is there. So that is why the people have start stopping the communication. So this is the one of the case where we have done the, after doing a, as you see, complete vitrection is very important to remove the vitreous traction. And here we are using a scleral plug. So from the sclera we are taking part of scleral tissue. The important thing is we have to have a watertight closure of that pit. The pit communication is deeper, not in the top, so that can be assessed with the OCT, swept source OCT. Now you can see with the VR, I am taking this flap and over the disc, and initially we were afraid because of the damage to the optic disc and circulation and all these things, but now we are confident of putting this scleral plug. Actually we have to identify how much is the size of the optic disc pit before inserting the this thing inside this, because of the we require watertight closure. And we have done ILM peeling, but ILM peeling is not that sufficient. It is not stick to the optic pit. Next presentation. So this is a case, as you can see above. This patient is a IB officer with vision of 636. I think he has come initially. So we have put the plug pointer. As you can see, this is a scleral plug, and you can see here also. ठीक है, होगा. So this is the one of the case where this is early resolution of the thing. The difference between just PPV is, in PPV in initial stage 5-6 years back I was not getting that response, and only 60% their fluid absorption are there. But this case, because it was watertight, and within a month fluid has absorbed, he's improved from 6/36 to 6/9. That to our surprise, because the retina must have been healthy in this case. So this is the old case where you can see the child has this girl has presented with 6/36 vision with huge cystic maculocytosis with NSD, and initially we have done PPV gas with laser. 6 months later on there was a recurrences. So again we have done the laser and the SF6 injection, SF6 in this case. Luckily the fovea was attached. You can see the laser mask, and the vision is still 6/6 in spite of having a fluid cystic cavity which has decreased, maculocytosis which has decreased, but not completely. Still after 2 years this is the same, but fovea is attached. Patient is lucky. So these are the advantages, disadvantages, and depend on morphology optic disc. Limited studies may dislocate. That's the important thing. Dislocation of the flap is very important in these cases. If we can fix it and decide, that's why the Hassan et al., he has done 20 cases and he has put this scleral plug and shown the 100% results. So another thing is plasma rich growth factor has been tried, and ILMP We have done the study, and we have seen within 6 months to 1 year there's an improvement in CMT and visual outcome. And there's a video which is just for 2 minutes. So this was the initial 3 years back. We have a AIOCMTC. This is to demonstrate the role of AIOCMTC in these cases. One thing is ILM peeling is not the standard of care these days. We have to do macular sparing, ILM peeling for the plugging of the pit, not to remove the traction, because tangential traction is not the cause in these cases. The tractional is at the vitreous, at the optic disc pit. There is a membrane or adhesion which has been shown by the various OCT, spectral OCT. And in the OCT here also, we can see whether there is a thinning of the fovea or not, so that we should be able to avoid. Still people are doing ILM peeling just for the sake of plugging of the pit, but that is easily available. But to me, it is very difficult to plug. So there is other method. People are putting amniotic membrane and scleral tissue. So we have already put this scleral tissue. Thank you for your kind attention.
Very nice presentation, Dr. Vora. I want to know whether you can plug this pit with autologous platelets also?
No, people are trying autologous serum. So that is why that thing is with the something with the.
So is it not fruitful? Is it
no,
not?
people are just doing. There is no study available. They have advised if you can put that thing with the calcium, it plug the hole.
Because
and the
in place
purpose.
of putting a plug,
Yes, yes. In place of plug or scleral flap, this may be the better idea in the futures.
And one thing more, in literature was mentioned the neurotomy on the periphery.
Yes, yes. That is the thing which neurotomy we have tried in CRVO cases are very difficult and complication rate was high. That is why we have not tried here. But Otto et al. Has shown the good results after doing because he said once you do retinal neurotomy, the fluid will comes out and it will close. Let me tell you, it is multifactorial factors. So earlier we used to know only the vitrectomy and we were not able to plug. Now the thing is, if you have to get a result, first do the PPV, remove the traction. If doesn't, then do the thing. The important factor in this case, long-term study is only available with me for the 10 years. In these cases where we do only PPV, the recurrences rate are higher as compared to the if you plug, because you are cutting both the sources, the vitreous traction as well as the CSF fluid coming from the CSF. Thank you. Anybody? Yes.
And also, what will you do in pediatric patients? Like, because vitrectomy, risk of cataract and all that, how long do you follow up those?
Yes. The case which I have shown is very, belong to one of the doctor, and she was diagnosed in 15. She was diagnosed in 15, the intraretinal fluid starts coming. So there is no visual fall. But what I think is many of the cases which I operated, their vision didn't improve earlier. Because if it is 6/36, it has become 660. But now with this experience, because the two cases which we have operated early, I think that case, first case, we were just one line improvement. And in the second case, again, there was a remarkable improvement. But all other cases which we have done 5 years back, there was not much improvement. That means now we are able to identify early and detect early. We should able to convince the patient it should be done as early as possible. 618 vision is sufficient, and patients should be able to convince. Because of vitreoretinal technology, microsurgery, everything has improved. So our surgical results has improved. So now don't worry about the thing. Although this thing, 618 vision is sufficient. That is the thing which we have done in our 20 cases. Pediatrics we are not touching. Being in pediatrics, the spontaneous resolution is there. But we are getting a patient of pediatrics, what you call, but if vision is left, we are operating. If vision is more than 6/18, we are not operating in these cases. As far as cataract formation is there, that is the issue. That's why we are not operating. So this is the case, the talk I am giving, because the early identification is very important. No one diagnosed or referred it. We have got the patient who was a IAS, this is a IB officer, he was having 630, not able to detect the vision. So for younger generation, you must do OCT, and if there is a macular detachment, you must see the pit and refer the patient as early as possible, or follow up in your clinic till the NSD occurs and visual fall and patient is agreeing for the surgery.
Thank you so much, sir.